Gracias. All right, so in the next 20 minutes, I'm going to review some of the important clinical and histological mimickers of celiac disease, and this will nicely complement the lectures that will come after that are dedicated to celiac disease, as well as another on enteropathies. So why is this topic important? This topic is important because when we make a diagnosis of celiac disease, we're committing someone to a lifelong gluten-free diet, which is not an easy diagnosis to give out, knowing you are significantly modifying how that person has to eat for the rest of their life. It affects how they go out to dinner, it affects social events, it affects travel. And we know that the availability and cost of gluten-free foods is definitely more challenging compared to those who can eat gluten-containing foods. So this topic is important because I feel like we should be as certain as we can before we label someone as having a diagnosis of celiac disease. So you're going to hear all about the tools that we use to diagnose celiac disease. And I'm going to just mention a few of them very briefly as I get into my deeper content. So typically, we will think about working someone up for celiac disease if they have some clinical concern, symptoms, laboratory finding, family members with celiac disease. And the nice thing about celiac disease is there's very good, sensitive, and specific serology to help support that diagnosis, which then can be confirmed with very characteristic biopsies, and typically you'll see people respond to a gluten-free diet. Now, the serology and biopsy are very contingent on someone eating a gluten-containing diet when you do that testing, because the positivity of those tests will decrease as someone is on a gluten-free diet. We also know that in terms of clinical symptoms, the symptoms for this condition vary widely. In the past, we used to think about those presenting with diarrhea, weight loss, and malabsorption, but you can see that in adults, 1/3 of patients present with non-GI symptoms. That could be peripheral neuropathy, it could be laboratory abnormalities with liver biochemistry abnormalities. And in children, how they present is even different than adults, with growth abnormalities, abdominal pain, other such things. Again, you're going to hear more about the serologies that we use, but when you look at the IgA tissue transglutaminase antibody, which is the screening test of choice, you can see that it's over 95% sensitive and specific. So if you have a patient who is TTG negative and serologically negative, you really need to take the steps to make sure you exclude something other than celiac disease, given the antibodies are so good. I'm going to take you through a few pictures of normal small bowel so that when I show you some comparative slides of patients with other enteropathies, you can compare that to what you see here. Very long finger-like villi, very short crypts. And when you look up close here, you can see there are a few scattered lymphocytes in the intraepithelial level, but very few. You can see goblet cells, which are those white punched out areas, which are very clearly delineated. And again, if you put this idea in your mind, when I show you some other slides, it will become quite apparent why having a good histopathologist is essential when you're looking at these cases. Again, this is histology of someone with celiac disease. You can see they typically have flattened villi or villus atrophy, partial or complete, and then they'll have crypt hyperplasia. So you can see on the left there how deep those crypts are. And then on a high-powered view, you can see a ton of lymphocytes in that intraepithelial lymphocyte or in that border, and the lamina propria is filled with chronic inflammatory cells. So now let's first talk about the different mimickers. And I'm going to divide this into what I call the early mimickers versus the late mimickers. By early mimickers, I mean those with very early histologic lesions. These are patients that if you think about the classic Marsh pathology. These are people with intraepithelial lymphocytes, but no villus atrophy. And this is really tricky because if your practice is like mine, you are seeing more and more biopsies from the small bowel coming back with increased intraepithelial lymphocytes, but no evidence of villus atrophy. And you can see since 2005, when the diagnosis of what makes increase in intraepithelial lymphocytes, it went from 40 down to 25. Despite that change, you can see the number of cases that have small bowel biopsies where you're going to find intraepithelial lymphocytes alone has increased. And this makes up more than 10% of duodenal biopsies that we see in our practice today. Yet 10% of patients with this finding do not have celiac disease, 10% of the population, I would say. If you look at the lower graph, when you exclude those patients with known celiac disease, very few of the patients who have this histologic finding actually have celiac disease, which makes it very challenging clinically, because that histologic finding could be a number of very common things. Non-steroidal anti-inflammatory drugs probably being the most common, H. pylori infection also being very common, bacterial overgrowth, a temporary viral gastroenteritis, or it can also be seen in inflammatory bowel disease. So again, when you see that histologic finding in someone who's serologically negative, these are going to be far more common than that diagnosis of celiac disease. So what do I do when I see that histologic finding? First, I often wonder why I took biopsies, because it puts me in this clinical conundrum. But the first thing I make sure is, were there adequate biopsies? Were they well-oriented? And then again, I confirm that this patient really truly does not have celiac antibodies, because if they do have antibody positivity, this could represent a very early histologic feature of celiac disease. But then I ask myself, why were biopsies done of the small bowel in the first place? What were the clinical features? Why was that performed? I will make sure they have an IgA level performed to make sure that they truly are seronegative and that they don't have an IgA deficiency. And I will think about checking their HLA, DQ2 or DQ8 positivity to see if they have that genetic propensity towards celiac disease. I'll then make sure to check to see if they have ibuprofen, Advil, Aleve, any non-steroidal use. Do they have H. pylori infection or other GI infection? And do they have any risk factor for bacterial overgrowth? Now, again, this is very tricky because, again, if I find something that is positive on that list, I will manage accordingly, hope that whatever were their clinical symptoms that resulted in that biopsy, that they resolve and you need to do no further testing. However, let's say there's nothing that explains that histologic finding. And again, this is where it gets very, very tricky. You could choose to look at their HLA haplotyping, and if they carry one of the genetic susceptible genes, you could consider putting them on a gluten-free diet. But the tricky part is most of those patients will probably have improved small bowel biopsies the next time you biopsy them, irregardless of what you did with their diet. So now, again, are you really going to commit someone to a lifelong gluten-free diet who has no antibodies and who only has intraepithelial lymphocytes? Very, very tricky. Let's talk about the late histologic mimickers, because I think these are a bit easier and we have more tools to differentiate them. So again, by late, remember, these are patients who have partial or total villus atrophy on their small bowel biopsies. So here are the typical things that you need to think about, and we'll talk about each one of these briefly. Autoimmune enteropathy, collagenous sprue, drug-induced enteropathy, immune deficiency, and tropical sprue. And there are some other very rare ones like Whipple's disease, which we won't talk about. So remember, those with autoimmune enteropathy, they will present in all of the same ways someone with celiac disease will have. They'll have chronic diarrhea, they'll have malabsorption. But again, what's really critical is having a good histopathologist who may notice that although this patient has villus atrophy, they have very, very few intraepithelial lymphocytes, which is distinctly different from those with celiac disease who have an excess number of intraepithelial lymphocytes. The other thing that they may notice is they have the absence of goblet or Paneth cells, which again, a very astute pathologist may notice. They may or may not have other autoantibodies because, again, I'll talk about the limitations of those. So we are seeing autoimmune enteropathy with increased frequency, probably because we're more aware to think about it. This is typically something we see in middle age, but there's often a delay in diagnosis because many of these patients in the past were diagnosed with serologically negative celiac disease, which led to a delay because they'd be put on a gluten-free diet and they would not clinically improve. And so the thing to think about with autoimmune enteropathy is this lives in the autoimmune spectrum. So they will often have other autoimmune disease. They may have autoimmune thyroid disease. They may have pulmonary fibrosis. They may have autoimmune hemolytic anemia or peripheral neuropathy, autoimmune liver disease, autoimmune kidney disease. So look for those other associations. There are antibodies that you could check, anti-goblet cell or anti-enterocyte antibodies, but they're very common and they're nonspecific, and they're seen very often in healthy patients. These patients may often have an ANA that's positive, so I will often use an autoimmune profile if I have this in the consideration. So you can compare these two slides that I'm showing. The one on the left is a patient with autoimmune enteropathy, and again, you may look at it quickly and say it looks just like someone with celiac disease. But look at the case on the right, which is someone with celiac disease. You can see all those white goblet cells in the case of celiac disease, but if you look at the left, you see none of those goblet cells in the intraepithelial border. So again, that's where a very astute pathologist would call that out for you. So if you suspect this condition, obviously you're going to get endoscopies that look compatible. You can check serology. And if you're suspicious that this could be autoimmune enteropathy, the most critical thing is make sure their nutrition is replete, because many of these patients will need total parenteral nutrition because they may be so malnourished. However, once you've made the diagnosis, these patients respond very, very well to steroid therapy, 85% of them responding to open capsule budesonide therapy. Once they respond to budesonide, you may taper them, and then if they need maintenance, you would treat this in a way similar to what you would with inflammatory bowel disease. Find some other disease-modifying agent, steroid-sparing agent to keep these patients on, although some may do very, very well with low-dose budesonide. Collagenous sprue. So again, this is a patient who will present in the same way of someone with celiac disease, diarrhea, malabsorption. But the difference that you will see histologically is they will have a very thickened collagen band. So normally you should see the collagen band being no thicker than one lymphocyte. But you can see in that lower picture, the lymphocytes are being just surrounded by collagen. So just at first pass, you can see that collagen band is very thick. So when we look historically at patients with collagenous sprue, again, these are typically patients in their 60s, more often white, more often women, who present with diarrhea and weight loss. Interestingly, more double compared to the normal population, they will have HLA compatible that you'd see with celiac disease. So some of them probably do have celiac disease that has morphed into collagenous sprue. But interestingly, in this look-back study, a third of those patients were on medications that were thought to cause the enteropathy that we'll talk about. So again, depending on what the cause is, these patients may respond to a gluten-free diet, but they also may need corticosteroid therapy. So how do I manage someone with collagenous sprue? Well, the most important thing that you first need to do is review their medications, because collagenous sprue is commonly associated with medications, which we'll talk about next. If they have either positive serology or HLA that's permissive and they're not on an offending drug, You would then think about putting them on a gluten-free diet, but many of these patients may also need immunosuppression based on the degree of their malabsorption, often again with oral open capsule budesonide. So I would say if you find a case of collagenous sprue, you're not done. You really need to do some homework to see if there's a medication that's causing this, or could this be celiac disease? So briefly talking about drug-induced enteropathy, the one that has really been, we've been made aware of in the last few years is olmesartan enteropathy, which is an angiotensin receptor blocker. So this came out as causing an enteropathy that completely mimics celiac disease other than it's serologically negative. Patients often are on this drug for years before they may develop an enteropathy, so make sure that you don't exclude that in your mind because the patient has been on it for years, because that's very common. When you know about this association and you stop the medication, most patients will have complete clinical remission with stopping the drug. So in addition to olmesartan, you need to think about other medications, checkpoint inhibitors, mycophenolate mofetil, methotrexate. And the one that I would add to this list are patients now that are undergoing CAR T therapy. Often they are now presenting with an enteropathy that looks like celiac disease and is often more severe than what we might see with checkpoint inhibitors. So remember, in a patient with a drug-induced enteropathy, first consider this in any patient who's serologically negative. Like I mentioned, an extra thick collagen band can be a clue to a drug-induced cause, although it's not always there. Like I mentioned with olmesartan, this can be started years prior to the onset of symptoms, which often leads to a delay in diagnosis. So in any case of drug-induced enteropathy, stop the medication if you're able. Obviously, if they're getting CAR T or they're on a checkpoint inhibitor or mycophenolate, you need to talk with their transplant physician or hematologist or oncologist before manipulating those medications. But many of these patients will need immunosuppression for improvement while the drug therapy is coming down or off. Combined variable immunodeficiency is something that we've learned about in our medical training, but oftentimes we overlook this. But these are patients with abnormal immunoglobulin production. So even though we think about this as a disease in younger patients, again, this could really present at any age. And even though we always were taught to think about that patient with recurrent respiratory and GI infections, oftentimes that's very mild compared to what you would expect. So again, don't wait for the patient to come in with frequent respiratory or GI infections before you think about this. So if you have someone with a serologically negative enteropathy, it really behooves you to check a panel of their immunoglobulin levels to make sure they're not immunoglobulin deficient. So what are some histologic clues to this diagnosis? Well, again, you can look at the picture there. They will have villous atrophy. They will have some increased intraepithelial lymphocytes. But if you look at that lamina propria, it almost looks empty. Because remember, in a patient with celiac disease, that will be packed full of chronic inflammatory cells. But these patients, because they have reduced plasma cells, their lamina propria almost looks near empty. And again, if you put that side by side with someone with celiac disease, you can see the difference in the lamina propria that's quite staggering. The thing that can be very tricky is you can have a patient with CVID who also has celiac disease, which can be very challenging to diagnose because their serologic markers for celiac disease may all be normal based on their immunoglobulin level. But for these patients, you give them immune globulin replacement and obviously have good infection prevention for these patients. And, finally, tropical sprue. So again, you may see this far more common in your practices than I do in mine. I think in my practice, we often have to make sure that we take, a really good history of where people have lived in the past and where they have had prolonged stay. We don't see this in patients who typically have a spring break in some warm climate. It is people who have had longer stays in these areas. But again, these are patients who present all the world like someone with celiac disease, diarrhea, malabsorption, and there's there's no serologic marker for this. So again, a good history is really important. And again, these patients are often put on a gluten-free diet for a prolonged period and don't get better because what they truly need is prolonged antibiotic therapy. So again, their biopsy can look all the world like celiac disease. There's really nothing that distinguishes it or differentiates it. So this is where it's really important to take a travel history or know where someone has chronically dwelled to make this diagnosis. And it might be a bit of trial and error, putting them on antibiotics for 6 months, and if they don't improve, you might need to think about other things because they still could have a serologically negative case of celiac disease. So just remember, all histologic findings are not specific. I mentioned the ones with villus atrophy to think about drug therapy, immunoglobulin deficiency, autoimmune enteropathy, tropical sprue, and Whipple's disease. So in this case, again, assuming you've had adequate small bowel histology and they're truly seronegative with partial or total villus atrophy, review the medications, check immunoglobulin levels, think about checking anti-enterocyte antibodies or ANA, knowing there's some limitations, take a careful travel history. If they're negative for any of those Mimickers and they have the HLA that are permissive for celiac disease, a gluten-free trial would be reasonable. If they do not carry one of those permissive genes, then starting immunosuppression would be the route to go. So again, just remember the usual histology in celiac disease, and just remember if you see any of those unusual things, especially if they're serologically negative, it should give you pause to do further workup. So take-home points, all enteropathy is not celiac disease, even though that is the most common cause of enteropathy. So really important to look for other clinical, laboratory, or histologic clues in the case of a serologically negative enteropathy, including a careful medication history and careful travel history. Thank you for your time and attention.